Mpox. Mpox, formerly known as monkeypox, is an infectious viral disease that can occur in humans and other animals. Symptoms include a rash that forms blisters and then crusts over, fever, and swollen lymph nodes. The illness is usually mild, and most of infected individuals recover within a few weeks without treatment. The time from exposure to the onset of symptoms ranges from 5 to 21 days, and symptoms typically last from 2 to 4 weeks. However, cases may be severe, especially in children, pregnant women, or people with suppressed immune systems. The disease is caused by the monkeypox virus, a zoonotic virus in the genus Orthopox virus. The variola virus, which causes smallpox, is also in this genus. Human-to-human transmission can occur through direct contact with infected skin or body fluids, including sexual contact. People remain infectious from the onset of symptoms until all the lesions have scabbed and healed. The virus may spread from infected animals through handling infected meat or via bites or scratches. Diagnosis can be confirmed by PCR testing a lesion for the virus DNA. Vaccination is recommended for those at high risk of infection. No vaccine has been developed specifically against Mpox, but smallpox vaccines have been found to be effective. There is no specific treatment for the disease, so the aim of treatment is to manage the symptoms and prevent complications. Antiviral drugs such as tecovirimat can be used to treat Mpox, although their effectiveness has not been proved. Mpox is endemic in Central and Western Africa, where several species of mammals are suspected to act as a natural reservoir of the virus. The first human cases were diagnosed in 1970 in Basankasu, Democratic Republic of the Congo. Since then, the frequency and severity of outbreaks have significantly increased, possibly as a result of waning immunity since the cessation of routine smallpox vaccination. A global outbreak of Clade 2 in 2022 to 2023 marked the first incidence of widespread community transmission outside of Africa. In July 2022, the World Health Organization, WHO, declared the outbreak a public health emergency of international concern, (PHEIC). The WHO reverted this status in May 2023 as the outbreak came under control, citing a combination of vaccination and public health information as successful control measures. An outbreak of clade Mpox was detected in the Democratic Republic of Congo during 2023. As of August 2024, it has spread to several African countries, raising concerns that it may have adapted to more sustained human transmission. On 14 August 2024, the WHO declared this outbreak a PHEIC nomenclature. The name monkeypox was originally coined because the disease was first identified in laboratory monkeys. This name was later criticized as a misnomer since monkeys are not the main host or reservoir. It was also criticized because the name reinforced racism and stigma about African countries as a source of disease. After requests by several public health organizations and scientists, who argued that these issues were hindering efforts to contain the disease outbreak, the subtypes of monkeypox virus were renamed in August 2022. The Congo Basin, Central African, clade was renamed clade I, and the West African clade was renamed clade II. In November 2022, the WHO announced that it will adopt the term Mpox in its communications, and encourages others to follow these recommendations. Signs and symptoms. Initial symptoms of Mpox infection are fever, muscle pains, and sore throat, followed by an itchy or painful rash, headache, swollen lymph nodes, and fatigue. Not everyone will exhibit the complete range of symptoms. Most Mpox patients become symptomatic 4 to 11 days after infection. However, the incubation period can be as short as 1 day. The 2022 to 2023 outbreak revealed that incubation periods of up to 4 weeks are possible, with 5% of cases having incubation periods longer than the previously assumed 21 days. The rash comprises many small lesions which may appear on the palms and soles, face, mouth and throat, genitals, or anus. They begin as small flat spots, before becoming small bumps, which then fill with fluid and subsequently burst and scab over, persisting for around 10 days. Some patients may manifest only a single sore from the disease, while others may have hundreds. A person can be infected with Mpox virus without showing any symptoms. Symptoms typically last for 2 to 4 weeks, but may last longer if the patient has a weakened immune system. Complications. Complications include secondary infections, pneumonia, sepsis, encephalitis, and loss of vision following corneal infection. Persons with weakened immune systems, whether due to medication, medical conditions, or HIV, are more likely to develop severe disease. If infection occurs during pregnancy, this may lead to stillbirth or other complications. Outcome. Provided there are no complications, sequelae are rare. After healing, the scabs may leave pale marks before becoming darker scars. Deaths. Historically, the case fatality rate, CFR, of past outbreaks was estimated at between 1% and 10%, with clade I considered to be more severe than clade II. The case fatality rate of the 2022 to 2023 global outbreak caused by clade IIB has been very low, estimated at 0.16%, with the majority of deaths in individuals who were already immunocompromised. In contrast, as of April 2024, the outbreak of clade I in DRC has a CFR of 4.9%. The huge difference between these estimates is attributed to differences in the virulence of clade I versus clade II. Underreporting of mild or asymptomatic cases in the endemic areas of Africa, which generally have poor healthcare infrastructure. Evolution of the virus to cause milder disease in humans. Better general health, and better health care, in the populations most affected by the 2022 to 2023 global outbreak. In other animals. It is thought that small mammals provide a reservoir for the virus in endemic areas. Spread among animals occurs via the fecal-oral route and through the nose, through wounds and eating infected meat. The disease has also been reported in a wide range of other animals including monkeys, anteaters, hedgehogs, prairie dogs, squirrels, and shrews. Signs and symptoms in animals are not well researched and further studies are in progress. There have been instances of animal infection outside of endemic Africa. During the 2003 U.S. outbreak, prairie dogs, Siamese ludovicianus, became infected and presented with fever, cough, sore eyes, poor feeding and rash. There has also been an instance of a domestic dog, Canis familiaris, which became infected displaying lesions and ulceration. Cause. Mpox in both humans and animals is caused by infection with the monkeypox virus, a double-stranded DNA virus in the genus Orthopox virus, family Poxviridae, making it closely related to the smallpox, cowpox, and vaccinia viruses. The two subtypes of virus are clade I and clade II. Clade II is further divided into subclades, clade DR and clade IIB. Cases identified as part of the 2022 to 2023 global outbreak are caused by clade IIB. Clade I is largely limited to the DRC and is estimated to cause more severe disease and higher mortality than clade ZR and IIB. The virus is considered to be endemic in tropical rainforest regions of Central and West Africa. In addition to monkeys, the virus has been identified in Gambian pouched rats, Chrysotomys gambianus, dormice, Grophyurus spp, and African squirrels, Heliosuvrus, and Funicerus. The use of these animals as food may be an important source of transmission to humans. Transmission. The natural reservoir of monkeypox virus is thought to be small mammals in tropical Africa. The virus can be transmitted from animal to human from bites or scratches, or during activities such as hunting, skinning, or cooking infected animals. The virus enters the body through broken skin, or mucosal surfaces such as the mouth, respiratory tract, or genitals. Mpox can be transmitted from one person to another through contact with infectious lesion material or fluid on the skin, in the mouth or on the genitals. This includes touching, close contact, and during sex. It may also spread by means of respiratory droplets produced by talking, coughing, or sneezing. During the 2022 to 2023 global outbreak of clade II, Transmission between people was almost exclusively via sexual contact. There is a lower risk of infection from fomites, objects which can become infectious after being touched by an infected person, such as clothing or bedding, but precautions should be taken. Diagnosis. Clinical differential diagnosis must consider other rash illnesses, such as chickenpox, measles, bacterial skin infections, scabies, syphilis and medication-associated allergies. Diagnosis can be verified by testing for the virus. Polymerase chain reaction, PCR, testing of samples from skin lesions is the preferred laboratory test. Prevention. Vaccine. Historically, smallpox vaccine had been reported to reduce the risk of Mpox among previously vaccinated persons in Africa. The decrease in immunity to pox viruses in exposed populations is a factor in the increasing prevalence of human pox. It is attributed to waning cross-protective immunity among those vaccinated before 1980, when mass smallpox vaccinations were discontinued, and to the gradually increasing proportion of unvaccinated individuals. As of August 2024, there are 4 vaccines in use to prevent Mpox, although supplies are limited. All were originally developed to combat smallpox. MVABN, marketed as Jynneos, Imvamune or Imvanex, manufactured by Bavarian Nordic. Licensed for use against Mpox in Europe, USA and Canada. LC16 from KMB Biologics, Japan, licensed for use in Japan. Orthopox Vac, licensed for use in Russia and manufactured by the State Research Center of Virology and Biotechnology Vector in Russia. COM 2000, manufactured by Emergent Biosolutions. Available, but not used, for use against Mpox in the USA. The MVABN vaccine, originally developed for smallpox, has been approved in the USA for use by persons who are either considered at high risk of exposure to Mpox, or who may have recently been exposed to it. The United States Centers for Disease Control and Prevention, CDC, recommends that persons investigating Mpox outbreaks, those caring for infected individuals or animals, and those exposed by close or intimate contact with infected individuals or animals should receive a vaccination. Other measures. The CDC has made detailed recommendations in addition to the standard precautions for infection control. These include that healthcare providers don a gown, mask, goggles, and a disposable filtering respirator, such as an N95, and that an infected person should be isolated in a private room to keep others from possible contact. Those living in countries where Mpox is endemic should avoid contact with sick mammals such as rodents, marsupials, non-human primates, dead or alive, that could harbor monkeypox virus, and should refrain from eating or handling wild game, bush meat. During the 2022 to 2023 outbreak, several public health authorities launched public awareness campaigns in order to reduce spread of the disease. Treatment. Most cases of Mpox present with mild symptoms, and there is complete recovery within 2 to 4 weeks. There is no specific treatment for the disease, although antivirals such as tecovirimat have been approved for the treatment of severe Mpox. A 2023 Cochrane review found no completed randomized controlled trials studying therapeutics for the treatment of Mpox. The review identified non-randomized controlled trials which evaluated the safety of therapeutics for Mpox, finding no significant risks from tecovirimat and low certainty evidence that suggests brincidofovir may cause mild liver injury. Pain is common and may be severe. Supportive care such as pain or fever control may be administered. Patients with mild disease should isolate at home, stay hydrated, eat well, and take steps to maintain their mental health. Patients who are at high risk from the disease include children, pregnant women, the elderly and those who are immunocompromised. For these patients, or those who have severe disease, hospital admission and careful monitoring of symptoms is recommended. Symptomatic treatment is recommended for complications such as proctitis and pruritus. A trial in the Democratic Republic of the Congo, DRC, found that the antiviral drug tecovirimat did not shorten the duration of Mpox lesions in patients with clade Mpox. Despite this, the trial's overall mortality rate of 1.7% was notably lower than the 3.6% or higher mortality rate seen in the DRC's general Mpox cases. This suggests that hospitalization and high-quality supportive care significantly improve outcomes for Mpox patients. The trial was sponsored by the NIH and co-led by the DRC's Institut National de Recherche Biomédicale, Epidemiology, History. Mpox was first identified as a distinct illness in 1958 among laboratory monkeys in Copenhagen, Denmark. The first documented cases in humans were in 1970, in 6 unvaccinated children during the smallpox eradication efforts, the first being a 9-month-old boy in the Democratic Republic of the Congo, DRC. From 1981 to 1986, over 300 cases of human pox were reported in the DRC, the majority being due to contact with animals. The virus has been detected in Gambian pouched rats, dormice and African squirrels, which are often used as food. Many more Mpox cases have been reported in Central and West Africa, and in the Democratic Republic of the Congo in particular. 2,000 cases per year are known between 2011 and 2014. The collected data is often incomplete and unconfirmed, which hinders realistic estimations of the number of cases of Mpox over time. Originally thought to be uncommon in humans, cases increased since the 1980s, possibly as a result of waning immunity since the stopping of routine smallpox vaccination. Future threat. The natural reservoir of monkeypox virus has not been conclusively determined. Small rodents are considered the most likely candidate. Without a major vaccination campaign, Mpox outbreaks in humans will continue indefinitely in the endemic areas, with an ongoing risk that disease outbreaks will spread to non-endemic areas. Other evidence, that the virus is evolving to be more transmissible among humans, that it can infect a wide range of host species, and that human-to-animal transmission can occur, led to concerns that Mpox may either become established in new natural reservoirs outside of Africa, or cause future global epidemics. Following the 2022 to 2023 outbreak, Mpox, clade IB, remains present in the human population outside Africa at very low levels. In November 2023, the WHO reported increasing numbers of cases of Mpox, clade I, in the Democratic Republic of the Congo, with 12,569 cases year-to-date and 651 fatalities. There was also the first evidence of sexual transmission of clade I. In 2024, the WHO added the monkeypox virus to its list of priority pathogens that could cause a pandemic. Outbreaks. This section is an incomplete list of disease outbreaks which have been reported, including significant outbreaks in the endemic countries in tropical Africa, Benin, Cameroon, the Central African Republic, the Democratic Republic of the Congo, Gabon, Ghana, Ivory Coast, Liberia, Nigeria, the Republic of the Congo, Sierra Leone, and South Sudan. Outbreaks of Mpox are frequent in areas where the disease is endemic. These areas often have poor healthcare infrastructure and outbreaks are rarely documented. United States. In May 2003, a young child became ill with fever and rash after being bitten by a prairie dog purchased at a local swap meet near Milwaukee, Wisconsin. In total, 71 cases of Mpox were reported through the 20th of June 2003. All cases were traced to Gambian pouched rats imported from Accra, Ghana, in April 2003 by a Texas exotic animal distributor. No deaths resulted. Electron microscopy and serologic studies were used to confirm that the disease was human pox. Everyone affected reported direct or close contact with prairie dogs, later found to be infected with the monkeypox virus. In July 2021, in the US, an American returning from a trip in Nigeria was diagnosed with Mpox. Subsequent testing identified the virus as belonging to clade II. The patient was hospitalized and treated with tecovirimat and was discharged after 32 days. Sudan. During 2022, an outbreak of clade I Mpox was reported in refugee camps in Sudan. The first case in the country was recorded in August, and in September, 6 additional cases were discovered in Khartoum. In October, more than 100 cases were reported among Ethiopian refugee camps, Nigeria. In September 2017, monkeypox virus was reported in Nigeria. The subsequent outbreak was, at that time, the largest ever outbreak of clade 2 of the virus, with 118 confirmed cases. Unlike previous outbreaks of this clade, infection was predominantly among young male adults and human-to-human transmission appears to have readily occurred. 7 deaths, 5 male, 2 female, case fatality rate of 6%, were reported, including a baby and 4 HIV/AIDS patients. Additionally, a pregnant woman in her second trimester had a spontaneous miscarriage attributed to monkeypox virus infection. In May 2022, the Nigerian government released a report stating that between 2017 and 2022, 558 cases were confirmed across 32 states and the Federal Capital Territory. There were 8 deaths reported, making for a 1.4% case fatality ratio. In 2022, NCDC implemented a National Technical Working Group for reporting and monitoring infections, strengthening response capacity. United Kingdom. In September 2018, the United Kingdom's first case of Mpox was recorded. The person, a Nigerian national, is believed to have contracted Mpox in Nigeria before travelling to the United Kingdom. A second case was confirmed in the town of Blackpool, with a further case that of a medical worker who cared for the case from Blackpool. In December 2019, Mpox was diagnosed in a person in southwest England who had travelled to the UK from Nigeria. In May 2021, in the UK, 2 cases of Mpox from a single household were identified by Public Health Wales. The index case had travelled from Nigeria. COVID guidance to isolate after travel helped detection of the outbreak and to prevent further transmission. Mpox cases were again identified in the UK in May 2022. Singapore. In May 2019, a 38-year-old man who travelled from Nigeria was hospitalised in an isolation ward at the National Centre for Infectious Diseases in Singapore, after being confirmed as the country's first case of Mpox. As a result, 22 people were quarantined. The case may have been linked to a simultaneous outbreak in Nigeria. 2022 to 2023 global outbreak. An outbreak of Mpox caused by clade IIB of the virus was first identified in May 2022. The first case was detected in London, United Kingdom, on the 6th of May, in a patient with a recent travel history from Nigeria, where the disease is endemic. Subsequent cases were reported in an increasing number of countries and regions. In July 2022, the WHO declared the outbreak a public health emergency of international concern. This status was terminated in May 2023 due to steady progress in controlling the spread of the disease, attributed to a combination of vaccination and public health information. As of January 2024, clade IIB Mpox cases outside of endemic regions in Africa continue to be reported at a low level. 2023 to 2024 Central Africa outbreak. During 2023, a clade I outbreak of Mpox disease in the Democratic Republic of Congo, DRC, resulted in 14,626 suspected cases being reported, with 654 associated deaths, making for a case fatality rate of 4.5%. The outbreak continued into 2024, with 3,576 suspected Mpox cases and 265 deaths reported in the DRC through the first 9 weeks of the year, making for an estimated CFR of 7.4%. Transmission of the virus in the outbreak appears to be primarily through sexual and close familial contact, with cases occurring in areas without a history of Mpox, such as South Kivu and Kinshasa. An estimated 64% of the cases and 85% of fatalities have occurred in children. The outbreak consists of 2 separate subvariants of clade I, with one of the subvariants having a novel mutation, making detection with standard assays unreliable. The outbreak spread to the neighboring country of the Republic of Congo, with 43 cases reported in March 2024. By early August the outbreak spread further into Central and Southern Africa with cases of clade I and clade II strains reported in Burundi, Rwanda, Uganda, Kenya, Côte d'Ivoire and South Africa. The WHO declared this a global health emergency on the 14th of August 2024. The following day, Sweden became the first non-African country to report a case of clade Mpox.